אני מברכת אתכם להגעה דרך הזום לסמינר המחקר הראשון שלנו של שנת הלימודים הזאת. כמו שתמיד אנחנו מנסים להביא לכם את האנשים שמובילים גם במחקר וגם בעשייה בתחום של האוטיזם, ובאמת כמו שלידיה אמרה לפני 5 דקות, אנחנו 3 שנים מנסים להזמין אותה, אבל בהחלט זה ברכה שאנחנו הצלחנו הפעם כן להזמין את לידיה. אני לא אקח הרבה זמן כדי לעבור על הביו הכי מפואר והכי מלא שיש לה, כי חבל לי על הזמן שלה. אבל אני רוצה כן להגיד לכם שלידיה היא מנהלת המכון להתפתחות הילד השם ויינברג בתל השומר, מאז 2004. המרכז הזה הוא באמת הוותיק ביותר והגדול ביותר שמתעסק עם בעיות נוירו-התפתחותיות בכלל, וכן לידיה מתעסקת לא רק באבחון, אלא גם כן בטיפול, ויוצאת בעצם מן העולם הזה והמפגש עם אנשים אמיתיים לעולם המחקר. התחומי עניין שלה במחקר הם בעצם אוטיזם מעבר לכל הגילאים, מתמקדות בגילאים היותר צעירים, אבל באמת בלהסתכל על אותם הדברים התסמיניים, זאת אומרת התסמונתיים, תקראו לזה מה שאתם רוצים, אבל סינדרומטיק אוטיזם, דברים שבאים עם הפרג'ל אקס ועם בעיות גנטיות אחרות, ואני חושבת שאחד, אנחנו לא יודעים משפיק על זה כי זה נדיר, ויותר מזה אני חושבת המבט הקליני, שהוא נפגש עם המבט המחקרי, יכול פשוט כל כך הרבה להוסיף לנו. אז אני שוב מודה לך מאוד, לידיה, שאת מחלקת איתנו את הידע, את הניסיון, ובעצם גם את האישיות המקסימה שלך. ואני מבקשת מכם לכתוב שאלות בצ'אט, ויהיה זמן גם בסוף לצ'אט, אם תכתבו את זה, ואני מרגישה שזה משהו שדורש התערבות, אני אתערב מבחינת לידיה, ואני אגיד רגע צריכים לתת הגדרה לזה, או לא יודעים את זה, אז תכתבו ואני אעשה את זה, ואני אבקש עוד פעם אחד, מאלו שכרגע הצטרפו, אם אתם יכולים בבקשה להדליק את הוידאו, כדי שנראה את הפרצופים שלכם, אני חושבת שזה משהו שמאוד מאוד מאוד ינעים לנו וייתן לנו כן את האפשרות להרגיש שאנחנו ביחד, למרות שבסופו של דבר אנחנו רחוקים אחד מהשני, וריבוע לא בא במקום כל האפשרות של ההנאה של להיפגש, לדבר וללמוד ביחד. אז ברוכים הבאים. לידיה.
תודה רבה.
אני הולכת לעשות אותך co-host, שאת יכולה לעשות את הדברים שלך, ואם יש עוד משהו, רק תבקשי.
שומעים אותי בסדר רק? אוקיי, טוב, יופי, אז תודה רבה, וממש תודה על ההקדמה כל כך מפרגנת ומחמיאה, ובאמת אני מקווה שאני אעמוד בציפיות. אני רואה שיש כאן אנשים שכבר שמעו אותי בעבר, אז אני מקווה שאני לא אשעמם אותם, ניסיתי לחדש בכמה דברים. ולבקשת פרופסור שולמן אני אעבור לאנגלית. אני באמת מאוד שמחה, גם זה מחמיא לפתוח את השנה הזאת, צפיתי והשתתפתי כמאזינה בהרבה סמינרים בעבר, ואני חושבת שזה מאוד מאוד תורם. ובאמת אחד היתרונות של התקופה הזאת, ויש מעט מאוד כאלה, זה שלפחות בזום אפשר לראות את הפנים של האנשים בלי המסכה, אז לפחות זה יותר נחמד כך. אני תוך כדי ההרצאה בעיקר מתמקדת בסלייד שאני הולכת להראות לכם, ולכן אם קורי תוכלי להסתכל על הצ'אט, אני לא אצליח לפצל את הקשר.
בשמחה.
בסדר? תודה, אז אני אתחיל בלנסות לשתף. שנייה. אוקיי, אתם רואים את המצגת?
אכן כן, תודה. הצלחת.
הצלחתי, כן. Okay, so I'll switch to English, and I thank you again very much for inviting me. It's a great pleasure to see you all. And I'll try to convey some of our more recent work and to talk a bit about what we're doing clinically at our center. And the title that describes most of the things that I'm going to present, I would like to emphasize the new approach to autism spectrum related disorders in a more precise way. All medicine, as you know, is going through a more personalized approach to the patient and to the family in all areas. And I think in our area, we have to be there as well. I will talk a bit about Fragile X syndrome as a model for genetically based interventions or treatments. And as Corey presented me, I'm the director of the Weinberg Center for Developmental Disabilities, and I established the Keshet Center for Autism quite a few years ago. And academically, I belong to the Sackler School of Medicine. My disclaimer is that I'm a medical advisor for a drug company called Ovid, and I performed clinical studies for Novartis, Alcobra, and Ovid drug companies that I'm going to talk about related to Fragile X. A bit about our center. We call it in Hebrew Keshet, and I assume most of you know the meaning of it, but it's actually an acronym. Initially, when I received the appointment as the director of the center, I tried to find an acronym that describes what we aim for, קידום טיפול ומחקר, שיפור תפקוד. But then it came more related in terms of the rainbow related to autism to call Keshet as קשיי שפה ותקשורת. So the Keshet Center became the Autism Center. Our vision is, of course, to be committed to the care of families struggling with developmental disabilities, with the more complex disorders, among them autism. We are a tertiary center, so many of the children that are overseeing are referred from other places. We provide a comprehensive diagnosis, treatment, research, and education. And our mission, as all the centers that deal with families with disabilities, we want to advance the children to their maximal level of independence and participation, to advance the standard of care, to promote research in prevention, early diagnosis, treatment, and outcome, to support families, and also to educate students, residents, fellows, professionals, but also families of normally or typically developing children in terms of inclusion and acceptance. As I said, we are a hospital-based center, so we deal with the more complex disorders or risk factors. We have some specific areas of expertise. Of course, the main one is the Keshet program, the autism program, but we have also a resource center for other disorders. We have quite a few collaborations, and I'm very proud to collaborate with most of the Israeli centers, and especially with you. And we have a recent paper together, and hopefully a new one in the near future related to COVID-19. We also have in-house collaborations with other labs in the hospital, universities. We deal with surveillance, and we try to influence health policy as far as we can put it on the map during those times. I'm very proud of the legacy of this center, so I want to spend a few words regarding to the roadmap because it has some interesting points during the history of the center. In 1960, it was established as a center for PKU. That's a disorder that by doing the neonatal screen, it's almost completely prevented nowadays. But that was most of the population that used to come then to that center for mental retardation. That's how it was called then. Of course, we're not using this term anymore. And for blind and disabled children. We have a debate whether it's the first or the second center in the country, but definitely it's among the first. In 1984, the first observational daycare center was established here, and it functions since until today. From 2004, when I came to the center, my mandate was to transform it to a tertiary center for referral for major disabilities and not to deal with some more simpler disorders that are dealt with in the community, and it's better that it would be dealt with at the specific HMOs. And then from 2006, we have the Keshet Center. From 2010, the Fragile X National Resource Center. And from 2-3 years ago, we established the Keshet program that I'll talk about it during the talk. We have also children treated in-house, about 100, and about 12 to 1,300 new children coming to our center each year. Here it's written more than a third with autism. It's actually more than 40% during the last year that are coming for something related to autism spectrum. But my aim is to try to convince you that we would like to approach autism in a more personalized, in a more precise way. In order to do so, I quote the definition of precision medicine, which is to enable the risk assessment, diagnosis, prevention, and therapy, specifically tailored to the unique characteristics of the individual, thus enhancing the quality of life and public health. So we think that this concept is very new. In medicine, you hear about it during the last few years in all areas of medicine. But actually, as many things that we think they're new, this concept, it's not so new. And I found in one of the books that were left here in the center by my predecessors, by Leo Kanner, a book called The History of the Care and Study of Mentally Retarded and the Dawn of the New Era. It's from 1964. There it's written, and excuse me for the wording, but that's what you can see in those books from the 60s and 70s. The feeble-minded are as heterogeneous a group of human beings as any other, deserving of the scientist's investigation and the physician's sympathy. And intellectual limitations are inextricably linked with the much discussed questions of the course of epilepsies, of symptoms, sequela, and the still puzzling riddle of heredity. Both this concept of heterogeneity, of differences among what he called feeble-minded, he included their intellectual impairment and autism as well, and the link to heredity or to genetics. It was a concept that was present already in 1964. But I think we advanced a lot since then, not only in regards to the language of how we called each diagnosis. I think nobody can start a talk about autism without discussing the increasing incidence. I know to this audience what I'm going to say, none of the things are new. But I just want to give an overview of the increasing incidence, which was actually at its peak probably in a paper from 2019. All those numbers are from the CDC. And the last one talks about 1 in 59, which is about the same as in 2018. So maybe we're now at some sort of highest limit that we're going to reach in terms of the autism prevalence. And as you know, there are many reasons for it, or many explanations, if not reasons. But in order to discuss the precise approach to autism, I have to discuss some of those explanations to the increase in incidence, though many of you are already familiar with those explanations. So what we have during the last few years, and even more than a few years, we have a broader diagnostic age. All of us are seeing younger and younger children that are being diagnosed. But also older adolescents and adults that were not diagnosed in the past, and there is an increased incidence of diagnosis in adolescents and young adults, and even not so young. So if for a few years we are diagnosing more people that were diagnosed before, either at young age, at older age, then we'll see for a few years an exponential growth in incidence. And I want to bring here a citation of a study that was performed in adults, and when a large cohort, I think it was more than 200 adults that were diagnosed with the same tools that we use today with using DSM-5 criteria. They reached about the same incidence in 1 in 59 adults with autism or with autism spectrum. So this kind of proves that if those adults were diagnosed 30 or 20 years ago, we wouldn't have this sort of very fast increase in incidence. So we have changes and better ascertainment of cases and better tools of diagnosis, which Corey promotes for many, many years here and teaches us to use those tools. So I think we're getting better in training the clinicians. We have better ascertainment of cases, but also we see that by using the new diagnostic criteria from DSM-5, we diagnose a bit more. It's said maybe in papers about 12% more people with more lower level of severity, like adolescents and young adults. So there is a small change in the diagnosis in the milder phenotype. But what I can see when I look at the complex diagnosis, that we definitely will have a very large increase in the diagnosis of the severe phenotype. Many of the children that in the past we diagnosed with intellectual disability, and the hallmark for this is Fragile X. I don't know if you remember, but before DSM-5 for Fragile X, we're not allowed to write a diagnosis of autism spectrum. They were only labeled as intellectual impaired. And now using DSM-5 criteria, between 40 and 70% of people with Fragile X syndrome are diagnosed with both intellectual disability and autism spectrum disorder. Many of them, almost all of the people with Fragile X have a lot of sensory issues, so they kind of automatically get the B4 criteria of sensory issues, but many other criteria that they meet, and many of them are being diagnosed with autism. And we see that with many other syndromes like Angelman syndrome, P10, many other syndromes that before were diagnosed with either developmental delay, intellectual impairment, they're being diagnosed now with autism spectrum as well. But we cannot ignore the influence of having more services and more interventions for the same child with Fragile X that before was diagnosed with intellectual impairment. When we change the diagnosis to autism, he will get more services, more interventions, and the child is the same child. So I'm sure this has some sort of influence, although we try to be very objective in the way that we diagnose those children. But it bears some weight, those laws that are not only in Israel, all over the world, that provide more services to children with autism than to children with intellectual impairment or even with CP. But besides all those explanations of having this high incidence, there are some papers talking about some true rise in the incidence that is valid. And not everything is conclusive, but there are some probably epigenetic factors that influence. There is a question about the influence of IVF, hormonal manipulations. I'll talk about one of our studies as well in this related to this. There is definitely a link to paternal age, and we see more and more children that both parental age is higher than it was before. And there is not a real increase in the incidence of prematurity. However, the link of prematurity in autism was made no more than 10 years ago. So more and more preemies are being recognized with autism and some other environmental factors. And I don't think I need to say to this audience, not immunizations. On contrary, some of the viruses that we immunize against. And also we have to think about fetal alcohol syndrome that is probably more prevalent that we recognize clinically. So after talking about the incidence and the big numbers, I want to allude to one child that will help me describe the way that we approach more personalized diagnosis and then maybe a more personalized treatment. Mayan, and the picture is with the, I show it to you with the approval of her mom, but please don't put it in the taped version. She was delivered after a normal pregnancy and delivery. She's a second child to her parents. And I first saw her when she was 8 months because she actually was not doing anything. She didn't have any milestones. She didn't have eye contact, no social smile, was not rolling over motor-wise. And she seemed dysmorphic. This picture taken at age 3, she's not as dysmorphic as she was as a baby. The facial features became a bit milder with age. Seeing all this combination of very severe global developmental delay. That was her initial diagnosis, which actually include, somebody can close the microphone.
חנה, את יכולה לעשות מיוט בבקשה?
So the initial diagnosis of Maayan, based on that she was extremely delayed in all areas of development, was very severe developmental delay. We measure it by the DQ, the developmental quotient. It was less than 30, like she was performing at less than 30% of her expected developmental age. And by seeing this dysmorphism, she was sent for a genetic workup and was diagnosed with a syndrome called Coffin series syndrome. I'm sure Sagiv knows it well. But when she was diagnosed quite a few years ago, she was the first child with this diagnosis in Israel. Since then, we know 9 or 10 families with this diagnosis, not all of them with the same gene that we found with Maayan. Maayan received very intensive interventions in all areas, and she was put in Ma'on Shikumi, which is the daycare for children who have motor problems mainly, and also cognitive problems, because her diagnosis was global. She was re-diagnosed at 1.5 years old. Again, her developmental quotient was 30. But in the next 2 to 3 years, she made progress in all areas of development, especially in her motor and fine motor skills. She became like very advanced. Seeing her doing more and more things, the daycare teachers noticed that she's doing more things, but she's extremely repetitive. She's very interested in augmentative communication in the iPad and the things that she can do with the iPad. She's less and less social, doesn't relate to any of the other kids in the class. At age 3 years, she was diagnosed with autism spectrum disorder, and her MDI, or developmental quotient, was 55. She continued with very intensive treatments, this time related to autism, but also by getting treatment in all areas, motor and fine motor language. She didn't develop so much of expressive language, so we worked a lot with augmentative communication with her, and she communicates very well all her needs and much more than that. She can converse with her iPad. When she was re-examined at 4 years of age, sorry, her IQ was already 75. She still had very clear-cut autism spectrum disorder, but you can see the progress in her cognitive abilities, and that's something that we can see in many of the kids that we treat, especially children with rare syndromes, but also you can see it in children with Down syndrome that is not so rare. That the very intensive therapies do change very significantly the cognitive achievements, but I cannot say did not influence so much the autism, because she improved in many ways, but she still has full-blown autism. And just to mention that in most genetic books, this syndrome is connected to dysmorphic features and intellectual disability. But looking at the mechanism, of the gene, we realized that since the gene is related to chromatin folding, it's very possible that it's a very strong autism gene. And it starts to become from an intellectual disability gene to an autism gene, like I said about Fragile X and many other genes that we knew in the past being related to intellectual disability. So when we look at the diagnosis that we made at our center, this is, I think, 2018, we see many syndromes that the phenotype is the autism spectrum, but those disorders are very different. We see disorders that we see this combination of autism and intellectual disability, or some physical features like the one that is more common, the velocardial-facial syndrome, that there is a cardiac problem, heart problem, and facial features, physical features. We see syndromes that are related to autism and epilepsy. We see quite a few syndromes that we see very specific psychiatric comorbidity, and of course many reasons that some of them are common and some of them are rare as the etiologies of the autism spectrum. So what I'm trying to convince you that we need to add this small s to when we talk about autism spectrum disorder. And we actually are looking at many rainbows. And that's from a waterfall in Canada that it was hard to take this picture, but there were like about 10 rainbows. I think in reality, when we talk about autism, there are much more. And this heterogeneity of autism spectrum relates to symptoms and severity, to the factors that are causing it. We see differences in twins studies with a very high link between monozygotic twins, but yet it's not 100%. And also when looking at twins, and all of us saw twins that are identical, you can see that even if both twins have autism, usually their phenotype is quite different. They don't have the same severity. So there are differences, even with the same genetic material, like in identical twins. We see differences in the development and the trajectory with people that are diagnosed as young children or as adults. And of course, I think all of us understand that many of the diagnoses that we make in adolescents or young adults, it's not because everybody else missed the diagnosis before. As it's listed in DSM-5, some of the children can cope until a specific age when they cannot cope anymore with the social demands, and then we make a later diagnosis. But on the other hand, we have babies and very young children that we see the diagnosis at very early age, and it's very clear cut. There are, of course, differences in comorbidity, in gender. Corey and your center is very involved with gender studies, and I don't have to preach about those differences, I'm sure. And of course, what I'm going to talk about all those differences in the reasons, in the etiologies of autism spectrum. And at the end of my talk, I'll allude a bit about differences in treatment responses based on this heterogeneity. So what I'm trying to say that although we have a common phenotype, we have common features that we diagnose by those features, there are many differences. And those differences are extremely specific to the level of the individual. So I want to tell you briefly about a few more stories. This is Mayan that you heard her story. This couple of teenagers, maybe some of you saw them at one of our Keshet conferences when they played beautifully on the piano. They are almost nonverbal with many behavioral issues, but being both of them autistic, I think you can appreciate how difficult it was for them to play in sync, and they played beautifully together and conversed actually through the music. That's a child that was born extremely premature and is high functioning with a very high cognitive level but has autism. Those children and the mother, all of them have Fragile X syndrome. The children have severe autism and very terrible behavior. And the mother is mildly involved with borderline intellectual abilities and some psychiatric issues. This child has a syndrome called ADNP. I examined him and diagnosed him in the States during my sabbatical. He has some typical facial feature that is hard to see in this picture. Since he had a diagnosis of this abnormal gene called ADNP, which is quite rare, the parents were able to pay for genome sequencing before he had any developmental exam or evaluation. They actually were raising him as having a syndrome that it's so rare that they thought that it's only specific for the child, and nobody would know how to treat their child because he has a very rare disorder. But when I see him and also my colleagues in the United States, it's clear that this child has global developmental delay and autism spectrum disorder. And we know how to treat and how to intervene for their child with the ADNP. And we don't have to wait for another thousands of kids with ADNP to be born to know how to approach this child in terms of interventions. Of course, like the parents were also hoping for treatment, and Professor Ilana Gozes is working on a genetically based treatment for this disorder. But nevertheless, this child can receive many, many other treatments, and I will try to convince you that they work, and I don't think that I need to convince you that the interventions work maybe much better than we can hope for a genetic-based treatment. And this adult, actually, he's now 30, his name is Yotam, and his parents are actually very proud when I'm showing his picture because he's has autism spectrum, intellectual disability with IQ of 49. He came to us as part of our drug studies in Fragile X. He participated actually in 2 studies. The reason for his autism is, of course, Fragile X syndrome. I think you can see a bit from his facial features. But probably mainly because of his parents' efforts, he succeeded to volunteer to the army for 3 years. And then he was recruited regularly for another 2 years. So he was 5 years in the army. And now he's working, he's providing for himself. He's almost independent. So I think that's a very nice achievement when you hear the cards that you were dealt with to begin with. So I'm bringing all those very, very different children and adults. I left this left one as a trivia. to try to convince you that if you've met one person with autism, we've met one person. I think we all know this quote. It's referred to as Dr. Stephen Shore, who's the person with autism. I think his doctor is in, his PhD is in education. But we all know and are aware about those differences. And just to give a small break to myself, I'll do a small quiz and ask you about this person that you see here on the left. And please don't look very fast in the Wikipedia, but I'll tell you his name. His name is Kim Peek, and please tell me how all of you know who he is, but not by name. You can open the microphone and tell me how I'm sure that all of you know Kim Peek or know about his story.
I don't know his story.
Okay, I assume all of you saw the movie or the show or the story of Rain Man. Okay, I think the movie was out in the 80s, so some of the younger audience maybe didn't see it then, but I'm sure, and I recommended that all of you will see it. So this person who deceased a few years ago, then his name is Kim Peek. He's the person that the movie is based on. As you saw in the movie, he has some special talents. But as you are, most of you autism experts, I'd like to ask you, based on the movie, whether Kim Peek was high functioning or low functioning, or how would you appreciate his level of function? And what do you think about his cognitive abilities?
אפשר לעשות unmute ולענות לשאלות של לידיה. Anyone can answer.
Okay, I'll try. I think he was a mixed bag because he was high in some and he was low in the other. So if I don't remember the character very well, but I understand that he had understanding. So cognitively he understood things, but his body, he had so much tics and Tourette or Rett syndrome, whatever you call it. So he looked low functioning.
I understand that his IQ was, he was considered to have a low IQ, but he was astonishing with his memory, his visual memory, especially for books. And that he required his father's help to get through the day. So if functioning is going by IQ, he would have been, I think, if he was intellectually disabled, then low functioning. And if it's going by his ability to function independently, then also. On the other hand, he had talents that nobody else has.
Yeah, right. So his IQ was not very low, but there were actually it was only one area that was very talented, but it's not a very functional area, like this memory and with numbers and the way that he could calculate. We see this in some kids that can calculate the specific day in the week that you were born 32 years ago, something like that. And this sort of specific ability, it's not very rare. And he had this special ability in this area. But in terms of his overall total IQ, it wasn't very high. But in terms of function, if you remember, he couldn't rest on his own. He couldn't take care of his hygiene. So his function was also quite low, and he wasn't actually independent. If you remember in the movie, the brother came and kind of kidnapped him from a group home that he was there, and then he kind of helped him in the everyday use of in dressing and all the daily activities. So his ADL was quite low. The real person, Kim Peek, was actually a bit more functional, but not completely. But the other reason that I wanted to bring his case, and not only as a trivia question, and to encourage you to see again the movie, which is very, very nice, is because it was revealed when he was alive. He had Kim Peek participated in some research studies related to brain imaging. And if you can see his facial appearance, he has a bit of dysmorphism in his facial appearance. And his MRI revealed that he had absent corpus callosum. It's the bridge that connects between the two parts of the brain. And the implications of absent corpus callosum are not always clear. There are some people that their outcome is probably fine, and sometimes this absence of this anatomic part of the connecting the two halves of the brain can have severe implications on motor development, cognitive development, and it has been for quite a few years linked also to autism spectrum disorder. And Kim Peek had autism spectrum disorder related to absent corpus callosum and to a genetic mutation that is causing this anatomic abnormality. So as you can see, each one of the pictures here has behind it a very unique story, although all of them have the same diagnosis.
Lydia, Amit, please, has a question. Can we listen to what his question is before you go on for a minute, or would you prefer to wait till the end?
No, it's fine, and if I'll answer it in my talk, then I'll tell him. If not, I'll answer it now. Yes, okay. What's the question?
I want to ask about savant syndrome. Savant syndrome is actually one from a biological point of view or not?
I didn't hear the last part. It's actually what?
If savant, because Kim was a savant, what it's called in the in the regular language.
Right.
So I ask if it's actually one from biological point of view, or it's many etiology for savant syndrome.
It's a very good question, and I don't think I have a good answer. We actually see, we call it now the special skills, which can be in music, in math, in many other areas. And it seems that those special skills are very common in many children. Some of them have a normal IQ or are even very intelligent. But many of the kids that have these special skills have low IQ and low functioning. But there is one area that they're extremely good. The problem with those skills that many times they're not very practical skills. So the way that we need to address it is how to take those skills and to make them more functional, something that they can help the child and not something that it's shown like in the circus, look how it's guessing numbers or something like that. But in terms of the reasons that what you're asking, I think there are many, many reasons, like the many different genes or many etiologies. And the reason that I think that the reasons are also very, very different is because we see those special skills, not only different children with the different genetic profile, but also we see it in children with a history of prematurity without like a specific genetic abnormality, just some brain dysfunction due to extreme prematurity. For example, the child that I showed you the picture with a helmet on, he's premature, but at age 2, he taught himself by playing with a keyboard all the letters in Hebrew and in English. The family is Hebrew speaking, and they didn't try to teach him, and they were very amazed about from this skill. But eventually his IQ is high, and he's very good in many areas now that he's about 10 or 12 years old. So I think the reasons for the special skills is quite obscure, and I don't think there is one reason why it's so common in many children. When trying to disperse this very different etiologies of to classify autism, that's kind of an old study that I combined the database from the center here and from my work in the States for quite a few years ago. We tried to separate a large cohort in the way that we separate epilepsy. Epilepsy, the basic classification of epilepsy, it's kind of an old classification, is by classifying epilepsy as being symptomatic, like having like a very clear-cut reason for either epilepsy or autism, by being cryptogenic, like we suspect that there is a reason, but we cannot prove it, and by being so-called idiopathic, like we don't have evidence of any additional neurological findings or disorders. And when we grouped those children by trying to classify it in this way, we found very valid differences between the symptomatic group and the idiopathic group. And those differences are related, for example, and there are many other differences that we found, but one of them that it's quite convincing is in terms of gender. In the idiopathic group, there were 5 to 6 boys to 1 girl. And in the symptomatic group, there were almost equal amount of girls and boys. And we also evaluated the prematurity group, that it was more related to the idiopathic. So since then, I had the suspicion that in prematurity, we kind of have a double hit insult, and I'll show you another more recent paper related to autism and prematurity. So when trying to group together all the specific reasons for autism, when we look at the diagnosis, I think we all understand that there is a very large overlap when the diagnosis of autism spectrum and global developmental delay and intellectual disability. But of course, there are kids that have autism without intellectual disability, and there is a group of kids that has intellectual disability without having autism. And some of this group is children with Down syndrome, that most of them have intellectual disability without autism. But as you may know, also some of the children with Down syndrome are not very social, and they have autism symptoms as well. But just when looking at this overlap, and I'm sure the proportions are not completely correct, and looking at the more recent literature, there are many genetic disorders that have been identified, either being here where there is a big overlap, like having both intellectual disability and autism as part of those of the phenotype of those disorders. There are disorders that have more tendency of autism without intellectual disability, with normal intelligence. But besides many of those disorders, and now they are in the last paper of Professor Buchsbaum from Mount Sinai, he listed 102 changes related to autism, genetic changes, and then he published recently an addendum of another 5 genes that are considered linked to autism, and they're linked not only by being recognized in kids with autism, but also linked by the function of the gene. Like, it makes sense that they're related to autism, and they're also are causing symptoms in the lab, in mice and other models. So many of those genes are very proven as being autism-related genes. But we also know that there are many other causes. Of course, prematurity that are mentioned, viruses during pregnancy, CMV was linked to autism, rubella, which we immunized everybody to prevent rubella during pregnancy. It's an infection that was very, very linked to causing autism and intellectual disability. Many insults that can happen around birth, and fetal alcohol. All of those are non-genetic etiologies, or at least combined etiologies for autism spectrum disorder or disorders. And I'll get back to this slide at the end of my talk to add you some more information to what I listed here. But I want to go back to a few examples to try to be more specific how we move from defining the reason for autism and to try to convince you why it's so important to know the reason, because we are in the era that maybe we can hope for treatment. And I like this quote of Thomas Insull, although I don't like that he used the term mental retardation still in 2014. But he said that just 2 years before that, he would think that mental retardation is a disability that needs rehabilitation, but not a disorder that needs medication, that can be treated. And he was referring to all the Fragile X studies that I'll describe some of them. And of course, you can see the link between those studies and autism targeted treatment. So one disorder that it's quite rare, but it's important to think about, it's a group of disorders called creatine deficiency syndromes. To discover it, we have to do specific tests, either in urine or by MRI in a technique called MRS. And this technique, it's actually looking through a metabolic window to the brain. And when you look through this metabolic window, we can see a few metabolites. And in kids that have this deficiency, we can see that this peak of creatine is missing. It can also be revealed in urine if we're looking for the specific disorder, but we need to look for it, otherwise we're missing it. And it's important to look for it because at least one or two of the syndromes that cause deficiency in this vitamin called creatine are treatable. So by giving creatine, we can improve function. It's just a vitamin. If you are allowed to go to health stores or to the gym, you can see like boxes of creatine because many people that exercise are taking it. After the corona, you can check it. It's just considered a food additive, but for those kids, it can make a huge difference in their development and their autism symptoms, not only by intervention, but by giving a targeted treatment, which is actually quite simple. The other venue to talk about targeted treatments is to talk about Fragile X. But for this, I prepared a somewhat longer introduction, and I see that we don't have so much time, so I try to hurry a bit. But I want to emphasize that when we talk about Fragile X, we have a syndrome that is causing intellectual disability, and it's causing autism in many of the cases. But we have a different syndrome of the people that bear the pre-mutation. They don't have the full syndrome, but they have different features. And when we talk about targeted treatments, we have to understand this difference between the full-blown syndrome and the pre-mutation, because they're completely different in terms of the mechanism and in terms of the syndrome, in terms of the symptoms. So just like 60 seconds on genetics, okay? As you know, we have chromosomes that I refer to them as books. Those books are, each volume is double volume. So we have 46 volumes, which each one resembles, like we're having like 2 almost identical copies of each book in our library. However, boys or males, the 23 chromosome is very different. There is X, when there is Y, which is much smaller with less genes. And females have 2 X chromosomes. So if we'll try to understand how we move from the chromosomes to the protein, there is a bridge in between, or a factory that translates all this information that we see in all those books to the proteins that build our body. And this transformation goes through this factory that Professor Ada Yonat got the Nobel Prize for recognizing some of the features of this translation factory. And the message is conveyed from the nucleus to the cell, to the protein in the cell, through a messenger called messenger RNA. So if we have in those 2 volumes of X of the girls, if we have in one of those X's multiplication of the zone of the Fragile X gene, and it's actually like a melody that repeats itself many, many times. All of us in our X chromosome and women in our 2 X chromosomes usually have between 25 and 54 repeats, or 55 repeats. But when this melody repeats more than 55 times, and actually more than 200 times, then this X chromosome becomes illegible. We cannot read what's written there. It cannot be translated to protein, and it's actually not functional. So girls can either express their completely normal X chromosome and be completely normal, or they can express then their illegible X chromosome with this X mutation, and then they will have the full-blown Fragile X syndrome like the boys. The boys, as you can see, they have only one X chromosome. So if their X chromosome has this like many repetitions, more than 200, then the messenger RNA cannot read it at all. So they don't have this very important protein. So they have always the full-blown Fragile X syndrome. They don't have another chromosome that can be normal and can help them. In terms of premutation, when we have between 55 or 56 and 199 repeats, this S chromosome is readable, but it's not very clear what it's written there. So this is called the premutation. And besides being transferred from generation to the generation and can become for the next generation illegible because it can change, it also can cause some symptoms related to premutation. Boys also that have this area of 56 to 199, they have a different symptomatology, but I will not get into it. So this mechanism of the transfer from the nucleus from the Fragile X zone that can either be with many repeats or with a normal number to repeats, translation into the protein through the messenger RNA, it was very much researched and I cannot say completely understood, but understood much better than in many other syndromes, how it happened, what are the different mechanisms, and how this protein is linked to intellectual disability and to autism. So this understanding about how the message is conveyed and what the protein is doing in the cell, it's actually kind of tempering down the amount of protein produced in the cell, and it works in balance with another receptor, but I will not get into it. But this understanding of this mechanism, what's happening with the normal gene, it's what's happening with the mutated gene, brought a lot of research that kind of tackled each one of those steps. And there are many drugs around and many clinical trials trying to change this mechanism. It's not called genetic modification because almost none of those drugs, only some very recent research is into trying to change the gene. But most of those drugs that are in clinical trial in Fragile X trying to change the mechanism that is causing the problem, that is causing the phenotype. And I will just mention again that in terms of the premutation, those drugs don't address the problems of premutation, only of the full mutation. But in the premutation zone that it's kind of close to 100, like people who have like 180 repeats and are considered premutation, we also see some symptoms of learning difficulties, intellectual disability, and there is a debate about autism spectrum in the premutated zone. But I want to show you here just the amount of drug studies that were performed based on this mechanism that it's understood or partially understood in Fragile X. And many of those drugs are trying not only to succeed in the Fragile X syndrome trials, but they're thinking also maybe being appropriate for treating other reasons for other reasons for autism besides Fragile X. But nevertheless, with so many trials, and that's an old slide, there are about twice as much from 2017. There is again and again a huge disappointment. Recently, there are 2 studies that are a bit more promising. And I want to quote this paper that appeared in the New York Times, that the parents for this specific child, but many of the children that we also saw and we were involved with some of those studies, were reporting amazing results. It's like holding the lid down, like the child open, like when we hear the children, when we hear the parents, and even when we see the children, we are amazed and extremely hopeful that here there is this drug trial is the next miracle for Fragile X syndrome. However, when looking at when those studies are being randomized, it seems that in all the studies, the placebo effect is so high that actually everybody improves. The placebo effect was about 40%. So for a drug to be better than 40% improvement is extremely difficult. And it's true what the families are seeing, and it's true what us, the clinicians, are seeing. All the children are improving. But it's not so sure that they're improving because of the medication. And that's like a small warning for believing to all the different case studies that we hear about, and thinking about the influence on of this placebo response, even in a population with intellectual disability and severe autism. I think I will go over this part of the talk and discuss another drug trial. This time it's our drug trial, our experiment. It took me 6 years of much less sleep, worrying about what's going to happen during this study. When you're doing a drug study, it's extremely stressful. And in this study, we combined a medication for Alzheimer called donepezil with a food additive called choline in a randomized study in 2 groups of children. We were very worried about side effects, so we gave quite low dose, and we didn't push it up. I will not go over the mechanism, but it's related to a neurotransmitter that is probably implicated in autism as well as in Alzheimer. And this study was published 1 year ago, and we found improvement, especially in expressive language, in the younger group of children. In the older group, in the adolescents, there were more side effects and less improvement. So like in other studies, we also assume that trying to influence younger brain and improve plasticity, it works better with a younger group of children. But all of us know that much more than all the drug studies that I'm mentioning, the main improvement that we can see is with very intensive intervention that we're providing. And by trying to convince you about the importance of developmental interventions, I'm bringing a study in mice. But I think it's very convincing. That's a study in mice with Fragile X knockout gene. So they have Fragile X syndrome. They have the full phenotype. And what they did in this very beautiful, it's kind of old studies. It's in 2005, but I think it's very, very nice because they took those mice, they put half of them in like regular mice cages, half of them in developmental center cages with many things around and a lot of attractions for the mice and a lot of TLC. And what's wonderful about this study that in the enriched cage, not only that the function of the mice changed, and I remind you, all of them had the same genetic disorder, all of them have Fragile X and autism and anxiety and many other features that you can see in mice. So their function improved, but also when looking at their brain, the structure of the brain changed. So by intervention, we're not only changing behavior, we're also changing the brain function. And it was on the changes resemble the same mechanism of some of the drugs that were experimented with. I'll go back to the table. So about 5 of the drugs here are assumed to make or presumed to make the same changes in this receptor of GLUR5 that was seen in the mice that were just treated by an enriched environment. And so I think that's a beautiful reference for what we're doing in terms of early intervention. So I'll mention our Keshet intervention program. I think most of you are familiar with it. It deals with...
Lydia, we don't have very much time because we'd like to spend some time also with questions. We would like to hear this, but I'm just giving you like a 5-minute update, okay?
I need less than 5 minutes. I'm almost done. Okay, so our program deals with parents, and some of our studies also deal with looking at parents. It's a parent-mediated early intervention. It's based on many other studies and interventions that involve parents at different degrees. It's an intensive program that combines different principles. I won't get into it. And we're trying to compare it to other interventions. But something that kind of precedes this intervention, we tried to look in children before they enter an intervention program as infants, and to see if there are differences in the way that parents address their children. Ariella, Dr. Yokel, who's here, she was very significant to this study. And we looked at the content of the way that mothers are addressing their babies that subsequently are being diagnosed with autism. And you can expect there are differences. So this became one of the cornerstones of intervention, how to make those adaptations to make the parents address the children differently, to try to teach them more language and social interaction. Another sort of intervention that we examined is the medical clowning. We try each one of the interventions to see if it has any scientific basis. And we saw that if the medical clown is trained, he can definitely contribute to all the different treatments that we're doing. Here is our clown actually trying to help us with getting blood lab work for one of the adolescents at our center. That's another study, but I will not get in depth. It's also with Ariella. She was very significant to our research center. And many studies that I will just go over the title that talk about gender differences, risk factors, and early signs. This wasn't the purpose of this talk, so I will not get much into it. But we looked at early signs such as motor delay. That's a more recent study of prematurity, and that's very interesting because we found gender differences in the risk of autism in prematurity. And just today we got accepted this paper, so I have to quote it, that we try to look at IVF And actually our results of outcome of IVF pregnancies is not as depressing as other studies. So it's a bit more reassuring that it's almost completely safe. We didn't find so much difference. So in summary, and I hope you're not holding your head like this child, we see also a specific treatment response that it's very different, that should be individualized according to age, to the specific syndrome, to gender, to comorbidity. And the general approach to intervention, I think about it like having a big traffic jam that is causing the phenotype of autism, and to try to go around this traffic jam. We can do it in many, many ways. We can open the jam, which is very challenging and usually doesn't happen. I know it every day when I have to drive from Rehovot to Tel HaShomer. Sometimes it's just better to go around and to find a different path. And many pathways to treatment have common response. That's of course an understatement about the interventions that are very, very general, and still they give us very good results for many reasons for autism. But another philosophical question is whether we need to treat or not to treat. For me as a clinician, that's extremely philosophical, because for all those people, there is no question. And my approach is to look at function, and where is the impairment in function, unlike in all those people that are thought maybe to be autistic. I'm not sure about part of them. Then if you have impairment in function, you need to treat. Otherwise, you can ask all the philosophical questions and have all the different answers. And I said that I'll go over this slide again at the end of my talk. All those syndromes that are here in white are syndromes that somewhere in the world there is a center that is looking for genetic-based treatment. I gave the example of Fragile X, but there are many, many more studies in this direction. Hopefully some of them will be successful. And we try to connect the parents in our project. It's called Hila Keshet, to those centers, and to try to figure out which researcher around the globe is interested in which syndrome, and to make those connections because it's very important for the families. It's very important for the specialists that are working in the lab to know that there are families struggling and they would like to participate in one of those studies. That's unrelated. That's the syllabus of a course that I'm teaching related to autism diagnosis, not ADOS and not ADI, just basic autism and developmental disabilities diagnosis. And that's our center, and Shiba, that was nominated among the 10 or 9 best hospitals, but main part that we do nothing on our own. We need to dream together and to make reality for our families, for the patients. That's a book that one of the psychologists wrote, and I recommend if you don't have it or know it. It's in a childish way a description of autism spectrum, but I think it's good for therapists and also for families. It's about siblings. Okay, so
thank you so much. We will all put our little clapping hands up here. It sounds and feels like you could have spoken for a full hour even after this one. You have so much to give us in the clinical world, seeing reality and functioning, but never stopping to look for some answers that both describe why we see what we see and what we can do to do it. I found your mouse model particularly amazingly hopeful that we can and will see changes. And I just want to say right now, thank you, thank you. It's so important. And I think we have time for one question, if there is such a thing, after such a full and amazing talk. Well, I can tell you that about 5 questions came up while you were talking, and I will be in touch to ask because there really was so much there. Let me thank you again. And if anyone has a question, you can direct it to us at the center and we will get a question from Lydia. Or as you heard, she is at Tel HaShomer running the program at the Weinstein Child Development Center. And I'm sure you can find her email on the internet as well. Lydia, I cannot thank you enough. It was so inspiring and so wonderful. Thank you very, very much.
I think Esther had a question. You want to ask?
Esther, do you want to ask your question?
We cannot hear you.
Yes, now we can. Stay close to the computer, please. No. Esther, push your mute button and then unmute it. Yes, much better. Thank you. I think that
Can you hear me now?
Yes, we can. Yes.
All right. I belong to a different group, and I feel that in the United States, they have so much information about the different kind of genetic issues. I'm trying to pinpoint, how do I find out what I have in my family if it's genetical? I've heard about a gene called MTHFR. Is there a way, a lab in which we can check and find out from where this autism is coming from? Because I need to find the real root of it. Do we have any answer in Israel as yet?
Actually, by working both in Israel and United States, I think the situation in Israel is much better than most states in the United States. In the workout basket of the state for autism, you can perform the Fragile X test and the chromosomal microarray. And also for kids that have combined autism and intellectual disability, the state pays for their exome sequencing, where you can find very, very small and specific genes other than can be found in the microarray. So there is a lot of testing provided in Israel. I didn't have time to present it, but our HILAP Keshet program is a program that connects parents that have the same disorder or questions regarding specific genetic disorders. And we're trying to find researchers around the globe to connect those parents to. So it's important to find a specific reason, and actually in Israel, it's paid for many of the kids with autism.
That was a really very focused answer. And I think, Esther, if you have more questions, what Lydia was also telling you is that they are interested in helping people get the information that they need. So if you like afterwards, I will send you her email and you may be in touch. Okay, lovely. So thank you once again, Lydia. On the chats, you will see that your compliments were, the compliments you got from the lecture were even better than mine. It was really an incredible privilege for us to hear all of the wonderful work that you're doing. Thank you so much.
I really hope we'll get to do much more together in the future.
It sounds like a plan to me.
That's a reason for presenting it, to find mutual interest. So thank you very much for inviting me.
Thank you. Thank you all for coming.
Bye.
תודה רבה.